All right. Thanks very much for the invite. It's great to be back here in Prague and test the waters for next year for the big event, for the even bigger event, perhaps. Yeah, great to be here. Thanks very much for the introduction. And Miroslav asked me to speak about guideline methods. And I'll take you through this presentation after I've shown you my disclosures. As Miroslav indicated, I have quite a few academic interests, working with the Great Working Group, being chair of the Guidelines International Network or the board of it, and working with Cochrane. But I don't have any financial conflicts of interest that in any way should distort what I'm going to say. So I know that many of you have heard about guidelines yesterday, and I will try to reduce any repetition. But I'm going to speak a little bit about what trustworthy guidelines are and how they can help us, and what the actual methods are to produce these guidelines. So I'll take us back a couple of years, despite the fact that nobody wants to hear about COVID anymore. We are just doing a very big guideline on post-COVID condition, and it happens to be still around. But I take us back a couple of years when we were seeing patients that were infected with COVID. Many of them presented with respiratory failure. In other words, as you remember, people had difficulties breathing, and these were some very typical CT findings that you're seeing there, basically the lungs being inflamed, having these opacifications. And one of the underlying hypotheses for why people were having these difficulties breathing, in particular when they were hospitalized, was that they were having small blood clots in the lung. You've probably heard about that, and that these blood clots actually cause the inflammation and the pictures that you are seeing there. So one of the questions, we had done a lot of work with the American Society of Hematology for several years. One of the big questions that came up was that should we give blood thinners to people who present with COVID and respiratory failure at a high dose to prevent these small blood clots from happening and people having respiratory failure. So a typical question that we posed, we had done this work with the American American Hematology Society, or Society for Hematology, over the years, and this new question came up, whether focusing on that CT scan there, whether or not in acutely ill hospitalized patients with COVID-19, we should give high dose, also called therapeutic, or intermediate dose anticoagulation blood thinners, compared to just giving what everybody usually receives, which is a low dose, a small injection, typically, and what the impact would be on outcomes such as mortality, these blood clots, and if you give people blood thinners, they are at a higher risk of bleeding, what the outcome would be on bleeding. So we phrased a typical question that many of you will be familiar with, but it's the format that helps you answer any question in healthcare about intervention effects using the so-called PICO format, defining the population, the intervention, the comparator, and the outcomes. And much of what we do, as I just said, in healthcare can be answered by phrasing good questions in this particular format. And what we came up with was that at the end of the day that the guideline development group suggested staying with the lower dose anticoagulation, despite the fact that there were autopsy studies and that there was other evidence that people were having higher risks of blood thinners, of blood clots. So we said that we suggest using the prophylactic, the low dose anticoagulation over intermediate or higher dose anticoagulation in patients with COVID-19 related acute illness, who did not have other indications for blood thinners. And we called this a conditional recommendation, and unfortunately, given that time frame or the time that this happened, it was based on really very low certainty that we had in any evidence about the effects. We had done very careful reviews, we talked to a lot of experts, but there was just not enough support to say that the bleeding risk would outweigh the reduction in blood clots. And what is very important as part of this guideline, you see that underlined here, that we said, nevertheless, at the end, clinicians should actually weigh the benefits and harms and follow up on what is the most up-to-date evidence. Okay, so that's how we confronted this. But what is behind this actual recommendation? It's a balancing of benefits or advantages and downsides or harms. And that is really the key question to anybody who picks up a textbook or picks up a clinical practice guideline to understand what the underlying health benefits and harms of an intervention are. And at the end, those of you who went to medical school, what we're interested in is to do no harm, right? Many of you still produce that oath when you finish medical school, those of you who went there. But that credo, the do no harm, actually has a slight flaw, that at the end of the day, what we're really interested in is to do no net harm. Right? I talked about the benefits and harms. What we're really interested in is weighing benefits and harms, because it's almost impossible to not cause harm. And I'll explain that a little bit better. So, and how can we achieve not doing any net harm? We're doing this through guidelines by carefully evaluating evidence and providing these type of messages that I just described. And guidelines are, those of you who were here yesterday, this is my favorite definition. Guidelines are systematically developed evidence-based statements that assist providers, recipients, and other stakeholders to make informed decisions about appropriate health interventions. And they should be based on evidence, but they always require consensus by people. And they require consensus if the evidence is very good, coming from many, many studies, or if the evidence is not so good, like in the case that I described, where there were very few cases. They always require consensus by somebody who makes these recommendations. And this is obviously, on the first pass, it looks like, well, you know, this is how we've always made decisions. But what I'm going to tell you is that this has actually changed quite dramatically in the way that these type of statements and guidelines are put together. Indeed, from this paper in the Annals of Internal Medicine, what we said is that the new era of guidelines promises recommendations that are actually based on the best available evidence, as opposed to just getting some people together in the room and acknowledging if the evidence is not so good, which means that oftentimes individualized decision-making is more important, and that they should be based on systematic reviews while providing, as I said, the necessary flexibility that is needed to individualize the decisions. And this is often misunderstood and misconstrued, indeed, as meaning that experts are now meaningless and not part of the process anymore. They may be even more important in the interpretation of the evidence and discussing that evidence. So I'll give you another quick example. It's one of my favorite examples. Poor Zoe, she just traveled many, many hours, 3 days, almost 2 days, let's say, from Australia. And one of the big questions that always comes up in people who travel long distance is whether or not they should actually prevent blood clots in their legs. So long distance travel is associated with a higher risk of having blood clots in your deep veins, in your lower extremities, and these blood clots, likely due to the fact that you don't move around very much and that the blood just gets stuck there. These blood clots can travel to your lung and cause a pulmonary embolism, as many of you know, and that can be really bad. So one of the big questions is whether or not people who travel for a long distance, like those, should be wearing compression stockings to prevent this from happening. And also here, we did a guideline a few years ago with the American Society of Hematology, and there were quite a few things that spoke in favor of making suggestions to people like Zoe to actually wear compression stockings when they go on longer flights, because it reduces the risk of deep venous thrombosis. However, the effect is extraordinarily small. On a flight for more than 4 hours, the effect is only about 3 to 11 per million people. Okay, so 1 million people need to wear compression stockings to prevent 3 to 11, or to have 3 to 11 fewer blood clots in the legs. However, around that, most people would say, I don't want to have a blood clot when I travel. You know, it's not that bad to actually wear these compression stockings, so the value that people place on the outcomes is probably not very uncertain. You know, everybody's probably thinking about this pretty much the same way, which speaks in favor of making suggestions or recommendations that everybody should wear them, despite the fact that the effect is so small. There's trivial side effects. You know, you can have a little bit of itching. There can be a little bit of rash when you wear these compression stockings. However, the certainty in these effects is actually also not very good, despite the fact that many, many people travel. We don't have really good randomized controlled trials to show that. However, based on what I just said, compression stockings, GCS here, are probably acceptable, and it's very feasible to do. You can buy them at the airports. However, buying them at the airport comes with quite significant costs. They cost about $60, which is probably about 50 euro if you buy a good pair. And if you think about this on a population level, you spend a lot of money on compression stockings to prevent a few blood clots. Okay. And in particular, for those who go on cheaper flights because their earnings are not as good and they fly low cost, the compression stockings may cost more than the actual flight, right? So think about that. If you are now a guideline panel and have to make suggestions or recommendations about this, there are lots of other factors than just these health benefits and harms that would influence if you make a population level recommendation. It's not only the prevention of blood clots or that, that rash that you might get. There's lots of other factors on a population level that influence the recommendation. And this process that I just took you through, this balancing, is what a guideline panel does. And when the guideline panel is convinced that there are more desirable consequences than undesirable consequences, we make strong recommendations. So the point that I'm trying to make is there's the health benefits and harms, but there are all these other factors that actually influence whether or not you make a recommendation. So is the intervention doable, acceptable, and is it equitable? So can everybody benefit from it? All right, so a good recommendation at the end of the day considers all of these options and all of these consequences, and therefore this process is not quite as easy. It's not just 10 people like me, experts in one clinical area, getting together in a room and figuring out what the best recommendation is. There needs to be scientific underpinning to it in order to really make the recommendations, like in this case, make the recommendations that are based on good evidence. So just as a brief recap, a recommendation then is an actionable statement that we provide to healthcare professionals so that they can do the best for the population that they are interacting with. A guideline contains one or more recommendations. That typically depends on the topic that is covered. I've done guidelines with a single recommendation. And the recommendations address really a variety of healthcare topics. So they go from public health to clinical, and all of that can be integrated in health policy in terms of decision making. So here's then a typical recommendation that we would have issued based on this balancing that I provided you with for Zoe and other people who travel long distance. In long-distance travelers without risk factors for VTE, the American Society of Hematology guideline panel suggests not using graduated compression stockings because the benefits are way too small to justify the costs that are involved with it. Of course, this is a conditional recommendation, which means that people actually can appropriately deviate from it. If they place a really high value on that very small risk reduction, they might invest these 50 euro or something like that and achieve this very small benefit. So and why do we need these guidelines? It's pretty obvious. If I were to tell you how difficult it was to compile that evidence for both of these recommendations that I showed you, the COVID recommendation and the actual travelers recommendation, that took a lot of time to understand how good these studies were that supported one or the other statement. Even in the first scenario, there was little evidence, but that made it even harder to understand what the underlying evidence really was out there. You need teams to do that. So, and there's not enough time for a single health professional to be able to summarize that evidence and actually make sense of it. Trustworthy guidelines explicitly consider then these desirable and undesirable consequences. They provide decision support, implementing these options, and they should be evidence-based statements that tell us exactly what to do, but leave room for individualization. So in order to really be confident in these two messages that I provided you with, these recommendations, there are a few features that trustworthy guidelines should actually fulfill. And this is coming from a number of organizations, including the World Health Organization, the Institute of Medicine that has spent a lot of time on that in the US, a lot of time on developing standards and methods for guidelines, the Guidelines International Network that is mentioned there, and a few other groups that have dedicated their existence to making sure that the healthcare messages that we provide in guidelines are actually based on the best available evidence. I will take you through 8 points that are relevant in this context. So first of all, it is important to involve a multidisciplinary group, diverse groups, including those who are affected, people with lived experience, for instance, if you think of HIV, TB, and even COVID. That they are based on really the best available evidence, which requires doing systematic reviews, that they consider patient subgroups, because not everybody is the same, that they integrate people's values. So I mentioned to you that most people would not want to have a blood clot. That is a value that people express. That they provide a clear explanation of any relationship between the intervention and the options and the outcomes, that they minimize distortions and biases, in particular conflicts of interest, which have played a major role, and I think most of us are not fully aware how much conflicts are driving healthcare decisions. So that is a big task of guideline developers, to minimize potential conflicts. That there's a rating of how certain we can be in the message that we provide, a rating of the certainty of the evidence, and that we provide a strength of our recommendation. I will explain that a little bit more. And that they're up to date. So they need to be revised as appropriate, in particular when there's new evidence emerging. So I'll take you through these 8 points rather quickly. I'll give you a couple of examples. So this is an example about integrating and working with people with lived conditions. So we did for the Italian national health system, the National Health Institute, it's called Istituto Superiore di Sanità. We did guidelines that were just published for the support of people living with autism spectrum disorder. And what we did there was we involved people who were caring for people with ASD, autism spectrum disorder, at all levels. And we involved caregivers, a mother was involved, and we had patients or people living with ASD on that panel. And that was extremely helpful because we actually learned a lot about what preferences for medications were and how the system actually is experienced by somebody having the condition. Right? So a diverse group of people should be involved. The second point, needless to say, you have Miroslav here, and it was probably a big part of yesterday's conversation. They should be based on a systematic review of the best available evidence. This is not about that we always have good evidence or that we focus only on the highest quality studies. Of course, we would like those, but reality often is that the best available evidence is not so good. But in order to know that, you need to systematically summarize it. So if you don't have all the evidence at hand and appraise it to inform a guideline recommendation, the answer will simply not be correct. So you need to do it well. So systematic reviews are a must, and there is very little conversation or discussion even about that anymore. They should be considering important patient subgroups. So recommendations must be tailored. So as an example, not all patients who have irregular heartbeats due to atrial fibrillation will have more benefits than harms from giving them blood thinners to prevent strokes, because that very much depends on how large your baseline risk is for having a stroke. Young people will have less benefit, absolutely speaking, than older people, which is a little counterintuitive, but that's how it is. So some people have a high risk of stroke, others have a low one. Some people have a high risk of bleeding if you give them blood thinners, others have a low risk of bleeding when you give them a blood thinner. And recommendations, therefore, should be tailored to those risk groups, which requires quite a bit of expertise in order to figure out whether or not there is net benefit in one group or the other. So baseline risk and risk groups have an important impact on what type of recommendations need to be made. And that, as a clinician, from an intuitive point of view, is extremely difficult, and it is why we need good guideline developers. They need to integrate people's values, so outcomes that are measured in research studies or that clinicians think are important may not be important to people. And that is the whole point here. So we need to ask the people affected by a condition to tell us which outcomes actually matter to them. They should be providing a clear explanation of the logical relationships between the alternative care options and the health outcomes. We use something that is called the GRADE system that was already mentioned, where we clearly, where we use a structured process to evaluate the existing evidence, looking at how well the research studies were done. Are they applicable to the population of interest? Do they produce similar results if the studies are done in different settings? Is there evidence not published that we should be aware of? And those type of factors. So a structured process to tell us at the end, is the evidence of high, moderate, low, or very low certainty before we go through a decision process. The decision process is based on what we call evidence to decision frameworks, criteria listed here. I already took you through them. Health benefits and harms, certainty of the evidence that is there. What are people's values that they put on it? What are the resources required? So think about the stockings example. Is it cost effective? Can everybody afford it? Equity. Is it feasible and acceptable? And that is based on evidence reviews and judgments. And we use modern tools for doing this, software tools, in order to structure the process in a way that it is reproducible. And we provide detailed information for why certain decisions are made. We provide a rationale. We do a guideline statement, such as here, that the guideline development group suggests something, and below that is a justification and how it should be implemented. That is part of a good guideline process. They should be based on an explicit and transparent process that minimizes distortions and biases. I mentioned that already. So a conflict of interest is actually an important potential source of bias in any guideline. And in a nutshell, it is the intentional misinterpretation of the underlying evidence. That is a conflict of interest. If you say something that is not supported and you know better, it is not supported by the evidence. We should be providing ratings of both the certainty of the evidence and the strength of the recommendation, as I said. For that, you have a network now in the Czech Republic that is working with the GRADE working group. That is a group that has dedicated its, as I said, existence to figuring out how we can assess evidence. One of the important definitions is about what is certainty in the evidence. The certainty is basically defined as an estimate of association or an effect is correct or better, that it actually falls within a certain range. So if I say there's a 5% risk reduction, how certain can we be that this outcome is reduced by 5% in a certain population? And we use different levels. There's a system that can be explicitly followed where we look at randomized studies and non-randomized studies and look at these criteria or the factors that I already mentioned to lower or increase the certainty. Without going into the detail here, this is all based on structured processes to, at the end of the day, make a recommendation either in favor or against an option. So it's important to say when you should stop something, these are recommendations against, either strong, when you really think there's inappropriate healthcare usage of an intervention, for instance, you make a strong recommendation against it, or there are scenarios where the desirable consequences outweigh the undesirable consequences, and that is when you make recommendations in favor, right? Where you say, everybody who comes to the emergency room with an acute myocardial infarction should get aspirin. That's a strong recommendation. Only very few people with an aspirin allergy should get an alternative treatment. And then lots of recommendations are in the middle. That is, you make a conditional recommendation. And then finally, before I sum up, they should be revised and reconsidered when new evidence emerges. Very brief story. 10 years ago, a new drug for tuberculosis was approved on the basis of 2 small trials. It suggested that despite the fact that there was lots of improvement in terms of how people with TB actually did, and the infection rates went down, people were cured from TB, there was an increased risk of dying based on these 2 studies. We waited very carefully and did very careful evaluation of forthcoming evidence, and at the end of the day, luckily, that was rated as very low certainty evidence. When the evidence accumulated, there was actually moderate certainty evidence that death was also reduced, which was much more in line with what just logical thinking was about. So these updates are critically important, and it changed the way that WHO made recommendations about that particular drug, bedaquiline. And finally, they must be developed by professionally trained individuals, and that is very important because guidelines affect millions of people. As a healthcare professional, I treat 1, maybe up to 1,000, a couple of thousand people. Guidelines affect millions of people, and therefore these guideline development efforts need to be done professionally. There's now certification programs. I make the pitch for it as a Guideline International Networks chair, such as the InGuide program, that is an international certification program, just like you get certified as a practitioner in healthcare. Thanks very much. This is my summary slide. So these are the 8 key points for trustworthy guideline recommendations. And the key issue is they must be done by professionals, such as institutions that you now have in place in the Czech Republic, with support from the community, obviously, in order to make sure that we address patients' needs and people's needs in an appropriate way. Thanks very much.